Our next speaker is Dr. Michael Luna, and I tell you, the final results are not in. We are still trying to decide whether he has H1N1 or Ebola, but apparently not feeling too well, but we appreciate him coming today. He also is from the UT Southwestern group, interventional cardiologist there, and he has the difficult task of tackling all complex coronary subsets in 10 minutes. And while he's coming, let me also say, and I'm sure y'all mentioned this again, all of these talks will be posted on the website. It's actually going to be on y'all's peripheral arterial disease, xlpad.org. All the talks and presentations will be posted there at the end of the day. So welcome, Michael.
Thank you much. I apologize up front if you were a witness to a hacking fit here. I'm trying to get over this miserable cold. I'm not actually going to talk about all complex angiographic subsets. It's too much to cover in 10 minutes. So I'm going to focus on one particular complex situation regarding CTO-PCI. So we'll start with a case. Mr. H is a 64-year-old man with heart failure, had CABG in 1994, and presented to our hospital with unstable angina. And here's his diagnostic angiogram. You can see his left coronary is diffusely diseased, starting at the left main, has an occlusion of his proximal circumflex, and then mid LAD is occluded. He actually has a patent lima. If you look over to the right, he has a patent graft that doesn't have the best flow in it, and if you look carefully, he has an anastomotic complex lesion, and this anastomosis is onto an obtuse marginal vessel. The vessel distally is a little underfilled as it distal to it being tented up by the graft. And if you look carefully, and this is important in this case, and that is that this vein graft backfills the AV groove circ, which goes on to supply some of the posterolateral wall here. So what are our treatment options? Well, the first one is and the most obvious one. That didn't show up too well. But that is to go ahead and try an intervention in the vein graft into the obtuse marginal. And the challenges here are pretty obvious, and that is landing the stent right where you want it might be difficult given the location of the lesion. And then you can compromise flow to the retrograde limb, which supplies a decent size of myocardium there. And the other option then is just to reconstruct the circumflex CTO. And there are multiple complexities here that might make this challenging. One benefit is that you have a vehicle, a donor vessel in the vein graft to allow for a retrograde option in terms of lesion crossing. Antegrade, the challenge there would be the fact that it's difficult to pinpoint exactly where the proximal cap is, and getting started in terms of lesion crossing might be challenging here. And so what's the problem with an antegrade dissection strategy here when the distal cap sits right at a point of bifurcation into an important side branch? And this is a crude drawing, but it sort of illustrates the issue here, and that is that if you try to tackle this in an antegrade fashion and your reentry is distal to the bifurcation, then you potentially, with angioplasty or stent implantation, would compromise access to your side branch. And this one, I would argue, would be an important side branch vessel. So you can see here's a dual angiography. Our plan here was to actually try to reconstruct the circumflex CTO. With the initial plan of a retrograde approach, trying to cross distally through the distal cap in a retrograde fashion, and we felt more comfortable that our chance of saving the AV groove circ was greater if we approached it this way. Unfortunately, what you can't see here in these pictures is the calcification of this occluded vessel. And this has likely been occluded for more than 20 years based on its CABG data. So we began an antegrade approach. Obviously, there's not much running room in the circumflex proximally, and so a ventral catheter was used, which is a deflectable catheter that allows us some directionality with our wires, and we were able to get the dissection plane started. And you can see here on the left, using a different wire, we're tearing through the proximal circumflex in a subintimal plane. You can see that I stopped short of the bifurcation. And I don't want to continue dissecting past the bifurcation with the idea that we would try to re-enter right at the bifurcation. On the right, you can see I've changed out for another Corsair catheter, and I've left the retrograde Corsair catheter in place as a marker of the distal cap. And so you can see this is a Stingray balloon, which is a re-entry device. It allows us to go from the subintimal space into the true lumen. And you can see that we've re-entered the vessel. My wire's going from the subintimal space in the proximal circumflex up here into the true lumen and into this obtuse marginal vessel. Now, although this re-entry is directed right at the bifurcation, and we attempt to do this proximal to either of the two branches, it's difficult to predict that. And the problem with dilation here is that if you do dilate into whichever vessel you get into, then you always have a potential to lose access to the other vessel, because there are tissue planes that are created when you dissect that could potentially seal off the other branch. And so the dilation after a wire crossing is achieved is an important step here, and I think it's important to try to stay proximal to the true bifurcation, so that you have some room to work in terms of re-entry into the side branch. And this is exactly what we're doing here. There's a wire in our true lumen in the obtuse marginal. We take a second wire to get into the AV groove circle right at the bifurcation distally. You can see the wire enter there. So now we have two wires in our two branches in an antegrade fashion. We've dilated the tracks up. What are our options in terms of stenting here? These are the various two-stent strategies that you can use. SKS, these are simultaneous kissing stents, is not a great option here. The problem with the T-stenting strategies is that when you create dissection planes at the bifurcation of these vessels, then you can, and you don't have adequate coverage with the stents, then you can have compromised the flow into the side branch, and so these are not great options. Culotte and crush techniques are both involve stenting the side branch first and then stenting the main branch. The difference with culotte as opposed to crush is that you have to lose access to your main branch when you're doing your side branch stent implantation, and this is not optimal in this type of CTO intervention when you've potentially lifted some tissue planes as you dissected. So crush really becomes the best form of stenting here, and you can see we did just that. There's a side branch stent that's inflated into the proximal circumflex with our main branch uninflated stent in place. Our wire and stent balloon is removed from the side branch, which I consider the AV groove circumflex, and the main branch stent is then deployed, and then we do kissing balloon inflations. And this is our final result. This after stenting all the way to the left main. This is not a great angiogram. My guide was not completely engaged, but you see very nice patency of both limbs here. So the important points I would say is when utilizing dissection reentry techniques in CTO PCI, specifically when the distal cap occurs at a site of a significant side branch, precise reentry allows for salvage of that side branch. And then the crush technique, I think, is probably the most secure two-stent approach when utilizing this technique at the bifurcation. All right, thank you.